Welcome to the kickoff of our 2017 educational webinar series. This month we have 5 complimentary webinars that will take a look at issues related to access and healthcare. I am Dr. Jill Brooks, Senior Director of Education for First Healthcare Compliance. At First Healthcare Compliance, we help you with a comprehensive compliance management solution tailored to your business, a hospital network, a healthcare practice of any size, billing company, or skilled nursing facility. As part of our complimentary educational webinar series, we bring you experts from around the country to discuss relevant topics in the healthcare industry. Today we are so pleased to have Ann Bachman of Doctors Management presenting Pama and how it will affect provider-based labs and reference labs. Established in 1956, Doctors Management is a full-service medical practice management and consulting firm offering industry experts in compliance, coding, auditing, financial services, patient retention, and human resources. Before I introduce Ann, I would like to take a moment to honor an individual from Doctors Management whose focus on continuing education is the reason this webinar came to be. James Russell Rusty Goosey was a senior management consultant for Doctors Management. Sadly, on September 11th, James passed away suddenly at the age of 32, leaving behind a family including 3 young children that he and his spouse had legally adopted after fostering. James had become an advocate for foster children, especially those affected by neonatal abstinence syndrome. James is greatly missed by friends and coworkers at Doctors Management. Ann has dedicated this webinar to him. Ann is the Director of Regulatory Compliance Department for Doctors Management and the Executive Director for the American Academy of Provider Offices and Laboratories. She has extensive experience in clinical testing, laboratory management and supervision, patient employee education, marketing, customer service, and leadership. She speaks nationally on regulatory compliance issues involving CLIA, HIPAA, and OSHA regulations. As the Director of Regulatory Compliance Department, Ann provides audits, training, and compliance manuals for doctors' offices across the country, assisting them with their OSHA, CLIA, and HIPAA compliance issues. She serves as a technical consultant and/or director for numerous physician office laboratories and is also an advisor to other laboratory-oriented entities. Ms. Bachman earned her BS degree from the University of Tennessee. She is professionally licensed as a medical technologist supervisor by the state of Tennessee, clinical laboratory scientist in the state of Louisiana, and as a medical technologist by the American Society of Clinical Pathologists. She is a certified laboratory consultant with American Medical Technologists and is a former president of the East Tennessee Society of Clinical Laboratory Science. She is also a certified medical practice manager. Her articles have appeared in POL News, Advanced for Laboratory Professionals, and the Tennessee Medical Association journal, Tennessee Medicine. She is a regular contributor to the AAPOL News newsletter and other trade journals. Ms. Bachman speaks at regional and national laboratory conferences, such as the POL Symposium sponsored by COLA and the Wisconsin School of Medicine. A copy of her slides are available for download on the control panel. There is an additional CLIA PDF. Feel free to submit questions into the question box during the presentation. Depending on the timing, we will address the questions at the end. Otherwise, your questions will be addressed directly by Ann via email. Your PACOM CU certificate will be emailed to you from PACOM following this broadcast. There is no need to request your certificate. Additional CEU opportunities will be available to BC Advantage members following the live broadcast. You'll see their website for details. Ann, go ahead.
Thank you, Dr. Brooks. We're going to talk about PAMA. This is something that has been tossed around for quite some time now and still is a lot misunderstood, shall we say. So let's just break it down and tell you what we know about it, what we can garner from the regulation itself, from other experts all around the country. PAMA is officially known as Protecting Access to Medicare Act of 2014, or H.R. 4302, signed into law April 1, 2014. The purpose of this was to amend the Social Security Act to extend Medicare payments to physicians and other provisions of the Medicare and Medicaid programs and for other purposes. What we're going to concentrate on really is Section 216. 216 is known as, or entitled, Improving Policies for Clinical Diagnostic Laboratory Tests. What that really means is that this regulation requires changes to the way Medicare pays for clinical laboratory tests under the Clinical Laboratory Fee Schedule, and you're going to hear that CLFS a lot. And they have a little disclaimer on their website because they're going to require a lot of reporting from laboratories around the country. And so their little confidentiality statement is that CMS cannot disclose payment data in a form that identifies a specific payer or laboratory or prices charged or payments made to any such laboratory except as is necessary to implement the rule. I did a little mini presentation last week to a group of my coworkers, and one of the questions at the end, because I just took a few slides out of this one, was, why are we doing this? And that is a really good question. The Medicare Part B Clinical Laboratory Fee Schedule, or that ubiquitous CLFS, originated in 1994 and was based on historical charge data at that time, not payment or value, but just what was being charged. It has been adjusted for many years now by crosswalking and gap filling, but not truly updated, not really overhauled as has long been needed. There has been a concern for some time that the government may be reimbursing for laboratory tests more than the private payers, and as you well know, that goes against Social Security rules. The Social Security law says that no one can charge Medicare for a laboratory test more than it charges anyone else. Well, you know you can charge whatever you want to, and the payers are going to pay what the payers pay. So the people who are buying the laboratory tests, the doctors or the patients or the hospitals, cannot charge. They can pay whatever, but the laboratories, that are providing the laboratory tests cannot charge the government more than it charges the hospitals or the doctors or whatever. But there's a concern that the government was actually paying more than the private payers, perhaps as much as 30%. So in end of 2013, beginning of 2014, CMS, or the Centers for Medicare and Medicaid Services, formerly known as HCFA, or the Healthcare Financing Administration, announced that it would revise this CLFS based on newer technologies. And there's really a lot more that has gone on to this. The proposed rule was published in September of 2015. The purpose, the bottom line, of PAMA is to update the clinical laboratory fee schedule for new tests and for new technologies. Yeah, that's good. To bring the payments that Medicare is actually making more into alignment with the payers, the private payers, what they're paying. And they really and truly, if we get a little more transparent, the purpose is really to decrease Medicare spending. Medicare expects to save almost $4 billion in the next 10 years. Now for the next little bit, we're going to focus on the traditional established clinical diagnostic laboratory tests. There's another part of PAMA that does address advanced diagnostic laboratory tests, but we're going to address that a little bit separately. A lot of the regulations are the same, but there are some very significant differences. So let's go back to Section 216, Medicare Clinical Diagnostic Laboratory Test Payment System, final rule effective August 22nd, 2016. That was not that long ago. It requires the submission of data from applicable laboratories beginning January 1, 2017, going to March 31st, 2017. That is as we speak. Ultimately, the payment on the clinical laboratory fee schedule should be equal to the weighted median of private payer rates as determined by all this data that CMS will get from all the laboratories, applicable laboratories around the country, and what they come up with from that. The timeline. The concerns really started in 2013, 2014, or the, I guess, the commitment to do something about it The proposed rule was 2015, the final rule 2016. The initial data gathering period for applicable laboratories is January 1 through June 30th, 2016. So yes, it's definitely a look back. That is a time frame that most any billing company or billing department should be able to mine and get this information. The initial reporting period for applicable laboratories is January 1 through March 31st, 2017. Then the revisions, shouldn't have said cuts. Some very optimistic person said, well, you know, some of the Medicare rates may actually go up. So anyway, the revisions begin January 1, 2018. That doesn't give CMS a whole lot of time. It gives them 9 months. So that is not a whole lot of time to throw all that data in their churns and churn it up and spit out the new fee schedules, because it's quite a lot of data, quite a few HCPCS codes that will be impacted by this. Now, let's talk about some of these dates. The dates have been changed for, to kind of meet the needs of the laboratories, and one healthcare advisory group has said that CMS has given the providers until 2018 to comply with the reporting requirements. But on the CMS website today, it still has the reporting period as already started and ending by by March 31st of this year. And there was a directive that went out from CMS January the 4th, 2017 that still gave those dates. Who is an applicable laboratory? We've kind of tossed that applicable laboratory bit around. This is a laboratory as defined by CLIA and that bills Medicare Part B under a National Provider Identifier or an NPI. So it starts with a CLIA certificate. The laboratory must receive 50% or more of its Medicare reimbursement from the physician fee schedule plus the clinical laboratory fee schedule, and must have received more than $12,500 in Medicare revenue from the clinical laboratory fee schedule during the 6-month collection period of January through June of last year. So we're going to take this criteria apart. The applicable laboratory criteria 1 must be a laboratory as defined by CLIA. So we start with a CLIA certificate. So any entity that does not have a CLIA certificate is automatically exempt from the reporting requirement. Then must bill Medicare Part B. So if the laboratory does not participate in Medicare, it would be exempt. An example here, or several examples, would be pediatrics. They're going to do Medicaid, not Medicare. Concierge practices, perhaps. There may be a few others, maybe OBGYN. You wouldn't expect a whole lot of babies being delivered for Medicare patients. The regulation says under its own NPI that the next part of the criteria is must bill Medicare Part B under an NPI. Clarification that we've gotten is that the NPI doesn't have to be assigned to the laboratory alone. Some places it says a unique NPI, but they have kind of gotten a lot of feedback and sort of revised that so that a laboratory that is a part of a physician office or an off-site laboratory, a satellite laboratory that's part of a bigger laboratory entity might have its own CLIA certificate, might have its own NPI, probably not, is more likely billing under the NPI of the larger organization, such as the laboratory, the practice. So it can be a larger entity. Now, one workaround that I tried to justify was a statement that I found in the regulation and the clarification that if a laboratory that is a part of a larger organization has its own separate MPI just for that laboratory, but not using it for billing, it is not an applicable laboratory. So what if a physician office laboratory that bills under the practice MPI got its own MPI but didn't use it for billing? I really wanted to advise our laboratories to do that, but I was so afraid that this is one of those gray areas under this regulation that we were going to get ourselves in a big snafu, which you'll learn about a little bit later on. So then the next criteria is that the laboratory must receive more than half of its Medicare revenue from the physician fee schedule added to the revenue from the clinical laboratory fee schedule. Now remember, this is only Medicare reimbursement for services provided to Medicare beneficiaries. So the formula is you add the amount of money that you got from the clinical laboratory fee schedule to the amount of money that you got from the physician fee schedule from Medicare and divide it by the total Medicare revenue. This is at the MPI level still. So this has helped determine whether it's an applicable laboratory. Now, the revenue, this is another workaround that we tried to justify. We thought perhaps with this physician fee schedule revenue, they meant only the laboratory-related revenue, but no, it includes all payments under Part A, Part B, Part C, Part D. So it includes office visits, radiology, any sort of drugs that may be dispensed in the practice. So for private practices, you're going to end up with basically 100% here. So that's why when we do our little protocol, our little decision tree, which we'll discuss later, we're leaving that out of it. So then we go to criteria 3. Must receive more than $12,500 in Medicare revenue from the clinical laboratory fee schedule alone during the 6-month data collection period. So this is what Medicare or CMS thought would exempt 95% of all physician office laboratories. The data period still is January 1 through June 30th of 2016, and it includes only revenue actually received. It doesn't include any outstanding balances, anything that's under review that you just haven't been reimbursed for. It's everything that you've received, but not outstanding balances at all. Having evaluated this and working with lots of labs across the country, the laboratories that might be exempt under this would primarily be laboratories that, first of all, don't take very much Medicare, if any. Maybe some urgent cares, because they don't see very many Medicare patients. Laboratories that are only doing waived tests, maybe provider perform microscopies, but don't do a whole lot of them. We can't say you're a waived laboratory, you're exempt, because waived laboratories really can get in a lot of revenue. It doesn't mean they make a lot of money from it, but they can receive a lot of revenue. So it's up to every laboratory to go through the decision tree that we're going to discuss later to come up with whether or not they're really an applicable laboratory. So once a laboratory has determined that it is indeed an applicable laboratory, it has to report. Now, it's not separated out by the type of laboratory. It's just those that meet the criteria, no matter what kind of laboratory you have. This does not at all apply to a collection station that doesn't perform or bill for laboratory testing. They would not even have a CLIA certificate, or would not need to have a CLIA certificate. That's one of the misunderstandings under CLIA. Well, we collect tests and we send it to LabCorp or Quest or the hospital laboratory. So we have a laboratory. No, you have a collection station, even though it may be within your physician office laboratory, and it may be staffed by a laboratory person. If you're not actually generating results, you're not a laboratory and do not need to have a CLIA certificate at all. So then the laboratories that receive less than that $12,500 per 6 months It's not per year, it's per 6 months, are exempt from the reporting. So let's take a moment and go through what we've named our PAMA protocol. It's a little decision tree, and it's what must you do. Step number 1, do you have a CLIA certificate? If you don't have a CLIA certificate, no, you're not an applicable laboratory, so you can stop there. So yes, you have a CLIA certificate. You need to determine whether or not your laboratory received $12,500 or more from Medicare for in-house laboratory testing performed on Medicare beneficiaries from January 1 through June 30th of 2016. If no, you can stop. You're not an applicable laboratory. If yes, for all intent and purposes for physician practices, then yes, you're an applicable laboratory and you need to go forward with the reporting, which we will discuss now. There may be some folks who are not real certain about whether or not they meet the 50% criteria, but really and truly in a physician practice, what do you get from Medicare other than monies from the clinical laboratory fee schedule and the physician fee schedule? So while the determination of an applicable laboratory is determined at the provider identification number, the NPI, National Provider Identifier, reporting is done at the tax identification number because one tax identification number can include multiple providers, national provider identifiers. And the example here would be, let's just say, a large physician practice that has satellite offices that may have each laboratory may be separate. So the determination of whether each one of those separate laboratories that has its own CLIA identifier would be required to report will be determined at that level, and then the reporting, if the practice decides it is overall an applicable laboratory, would be done at the tax ID number. The other thing that they clarified, which is a little bit odd here, is that laboratories that are not applicable laboratories that don't meet the criteria are not allowed to voluntarily report. Well, why would they want to? There is a concern among the laboratory industry that ultimately the applicable laboratories that are reporting will ultimately be those really large reference labs with economies of scale and with large, greatly reduced managed care contracts, and that this will throw that weighted median of private payer rates to below costs for a lot of other laboratories. So some of the smaller labs would like to throw their information in there so it doesn't appear to get so skewed. What must be reported? The HCPCS codes, and this is all done, by the way, electronically, and you'll see a little bit more about that. So on the PAMA portion of the clinical laboratory fees schedule page of CMS, there's actually a list of HCPCS codes that must be reported. The number of each of those tests done for each payer and how much the laboratory received during that time frame for each analyte from each private payer, and this includes out-of-network payments, any patient costs, sharing, or co-pays. And once again, there's a little bit of difference for the advanced diagnostic laboratory tests, which we'll get to in a moment. There are some things that do not have to be reported, and this will be capitated reimbursement, private payer rates where there's several tests thrown into one test reimbursement, where situations where you cannot tell how many of these you actually paid for. So all three of these, the multiple tests paid with a single dollar amount, these are items where you can't pull out a particular HCPCS code and really very easily determine how much you were actually paid for that particular test. Things are just lumped together DRGs might be an example. And also anything that has not yet been paid, that's been denied or is under appeal. Then we have to determine what is a private payer. It's a health insurance and a group insurance plan. It includes even Medicare Advantage plan under Part C, basically anything that's not Medicare. Medicaid is considered a private payer. Self-pay, secondary insurance, these are all private payers. And how is the reporting to be done? This was a big concern because this has only recently been released. This will be done totally online using an Excel spreadsheet template, and here is how you get to that template. Also, the list of HCPCS codes that have to be reported are available, and this template will accept only the HCPCS codes that that are covered under this particular regulation. There's a lot of information on how to fill out this form on the CMS website, and we do have something that's really good from MLN Matters, a screenshot from the actual guidance. This is very helpful. Then we have a screenshot on slide 24 of what the template actually looks like. So it's going to tell you exactly how to fill this out. And there are two individuals that are identified as participating in this process. One is the person who is actually doing the reporting, who is entering this information and submitting it to CMS. That person has to actually be registered, and it will describe to you how that has to be done. And then there's someone who certifies the accuracy of this, and you'll see what we're talking about on that a little bit later as well. So you have two individuals who have to be identified as doing this, the one who enters the data and submits it, and the person who certifies that it is accurate. The reason that they're requiring that someone certifies this is that there is actually a penalty for noncompliance. The penalties can be up to $10,000 per day for failure to report, for each omission, and for each misrepresentation. So this can be huge. And here's where I have a little bit of a bone to pick, if you will, with CMS. CMS knows all of their certificates. They issue the CLIA certificates, so they know who has a CLIA certificate. They're the ones that reimburse on the for Medicare beneficiaries, and that's the only thing we're really talking about at this point when it comes to determining whether it's an applicable laboratory. They know how much they reimburse you off the clinical laboratory fee schedule and the physician fee schedule. Why don't they just say, you and you have to report, the rest of you don't? But they're leaving it up to the laboratories to crunch the numbers, to make the determination, and to be honest in their reporting. This is the part of it that I can see easily being delayed. On the CMS website from January 1st of this year, they're still saying the reporting has to be done by March 31st. And when you pull up the reporting page with the template, it's still saying this has to be submitted to us by March 31st of this year. I can totally see extending that deadline, although the reporting, it's open. If anyone has already crunched the numbers and done their all their data gathering, they could certainly enter that information right now. It's open. It's easy to use, or it's ready to use. And it's better to err on the side of conservatism always, and to report now. If everybody waits till the very last minute and says, oh, they're not going to extend it to September or December or whatever, then the system is going to be overloaded, and a lot of people are not going to be able to report by that deadline. So rather than holding your breath and waiting until March the 28th, deciding, well, I guess we better report, my advice to you is to go ahead and do your reporting now. So let's talk about what the ultimate revisions may be, and we're still considering that the majority of them, if not all of them, will indeed be cuts. So CMS is going to get all this information from all the applicable laboratories across the United States. They're going to toss it in their churn, they're going to churn it up, and they're going to spit out new numbers that are supposed to be the new fee schedule that's supposed to start January 1, 2018. I can see them not having that ready because CMS always sets these deadlines, and who is always the latest to be able to comply with the deadlines that they set? Didn't say that. So there are maximum reductions. They say nothing about increases, but the maximum reductions are 10% per year for the first 3 years and 15% reductions the next 3 years for a total of a maximum of 75%. Now, I cannot envision that taking place. I can envision the example that we're going to show you being quite common. So let's emphasize here that the revised fee schedule will apply to all laboratories, not just to. This will apply across the board to everyone, and they will be in place year at a time. The phasing in happens until the Medicare fee equals that median rate paid by private payers. In some geographical areas, people are telling us that clinical laboratory diagnostic tests are already reimbursed by Medicare less than private payers. And I think that's a geographical issue, and some of that is yet to be seen. So here is our big example, and this is straight from Medicare, from CMS. Let's say that for test A, the private payer weighted median rate is $15, but Medicare's national limitation amount is $20. Now that's significantly higher, but they're not going to reduce it all at one time. Year one, which is 2018, they will reduce it by a maximum of 10%, which is $2, taking it down to $18. In 2019, they will reduce the 2018 rate by another 10%, or $1.80, bringing it down to $16.20. The third year, 2020, it's actually going to be less than that 10% maximum, because they will reach that $15 national payer rate that they've determined from all the information that they've gotten. So it will be set at $20. I'm sorry, at $15 to match the national payer rate. So the further reductions won't happen at this time. Because there's more. This is not a once and done project. It has to be repeated every 3 years. So every 3 years, every CLIA certified laboratory must determine if it is an applicable laboratory. A good scenario came up quite recently in some of our discussions. Let's say we have a laboratory that would otherwise have been an applicable laboratory in 2015, but they went out of business or dropped back to wave testing in February of 2016, so their reimbursement for that entire reporting period or data gathering period is probably going to be below the $12,500. On the flip side of that, you could have a laboratory that just started or that went from wave to non-wave and grew its test menu significantly. It would not have been an applicable laboratory in 2015, 15, but now their revenue exceeds that 12,500, so it is indeed an applicable laboratory. So this has to be done every 3 years. Do you have a CLIA certificate? Do you make or do you receive from Medicare $12,500 or more off the clinical laboratory fee schedule? And then in a really large entity that gets revenue from something other than the clinical laboratory fee schedule and the physician fee schedule, you would want to determine whether or not that meets the criteria of 50% or more. So it's every 3 years. The next data gathering period will be January 1 through June 20th of 2016, with the reporting period the following first quarter of 2019, then the reporting period the first quarter of 2020, and so on. And at this point, it's every 3 years. And CMS, although there's the thought out there that CMS might delay the reporting period, it still seems to be that that's what we're going on right now. They would have to make a lot of changes very quickly in order to delay that. Now let's talk about those advanced diagnostic laboratory tests, a different animal altogether. As defined by Pama, this is a clinical laboratory test offered and furnished only by a single laboratory, and it is not sold for use by a laboratory other than the original developing laboratory or a successor owner that meets some criteria on the next slide. Now, a little clarification here. Is this single laboratory, it could actually be, they're trying to include in here a laboratory that might have some satellite sites, but it does not include some other entity, say a large reference lab or a hospital lab, that buys that and then commercializes it and lets other laboratories buy it. So it's what we in the laboratory industry think of as a laboratory developed test. So a laboratory develops a particular, most of these are molecular tests or genetic tests. They develop a laboratory test for a specific disease. And they, as long as they're the only entity that tests for that, and they can accept specimens from all over the country and release the results to the ordering providers, but they can't then turn around and sell it to another laboratory that sets up a testing facility somewhere else. They might have an additional, they might be able to get away with an additional site that's still under the same umbrella, the same ownership. Ownership is what's important here. So as defined once again by Pama, this is a test that is an analysis of multiple biomarkers, RNA, DNA, or proteins combined with a unique algorithm to yield a single patient-specific result. The test is cleared or approved by the Food and Drug Administration or FDA, or it meets other similar established criteria as established by the Secretary. This is one of those places where they've learned in the past not to put certain limits on themselves. So this gives CMS an opportunity to, based on new technologies, new testing discoveries, shall we say, to add some criteria to this later on. So we say this advanced diagnostic laboratory test must yield a result that predicts the probability that a specific patient will develop a certain condition or respond to a particular therapy. This must provide new clinical diagnostic information that cannot be obtained from any other test or combination of tests and cannot be offered in another laboratory. So remember, these are going to be treated a little bit different from the clinical laboratory diagnostic test that we're used to. The new advanced diagnostic laboratory test will be paid initially according to the actual charge during the initial period. The actual list charge is that charge that is publicly available on the first day that this new test can be obtained by a patient who is covered by insurance. In other words, it's not, it's out of the research and the clinical trial arena. It is now can be purchased on the behalf of a patient. So on the first day, this new test is marketed to the public. So it's the first time that it's totally out of the research or clinical trial arena. Now it's available commercially from that one laboratory, but now my doctor can order that test for me and get my result wherever I may live. So the initial period for a new advanced diagnostic laboratory test begins on the first day of the first full calendar quarter. That gets real involved, following the date that a Medicare Part B coverage decision is made, or the date that the test status is granted by CMS, whichever is later. So it's not the first day. The initial period begins the first day of the first full quarter. So that gets it a little more confusing. So then after this initial period is over, this test will be based on the weighted median private payer rate that this laboratory is actually receiving. And you're going to learn in just a moment how often they're going to have to be reporting. Instead of every 3 years, when a laboratory has a new ADLT or an ADLT period, the reporting is every 3 years. Coding has been very problematic for new tests, whether they're ADLTS or CDLTS. This has been a very slow, onerous process, and there's been a lot of well, I won't say hacking, but more like crosswalking and gap filling. So the Pama regulation does encourage the AMA to create new current procedural terminology codes, and they are actually working to meet this new coding process, so it won't be such a lag time between a test being developed and getting its own CPT code. So here's the biggie here, is that the threshold for exclusion of $12,500 in that 6-month reporting period, not just the one of 2016, but each year, does not apply. So if a laboratory gets $1 in that 6-month period for an advanced diagnostic laboratory test, first of all, they're going to go bankrupt immediately, but they still have to report. And while the data gathering and reporting periods are the same months as for the clinical diagnostic laboratory test, for the ADLTS it's every year. And so this is going to pick up those new tests as they come along much more quickly than if it were every 3 years. And I think that's the purpose there, is they want to get these folks on board and fully functional with the revised rates every year rather than every 3 years. So we're doing really well on our timing, and our last slide we have to address is the elephant in the room, and this is, what will Trump do? We have absolutely no idea. While this is, PAMA is linked most directly to the Social Security Act, there is a little overlap with the ACA, the Affordable Care Act, which the new administration is trying to replace. They're struggling to replace the Affordable Care Act itself. What are they actually going to do with PAMA per se? With the, let's just say, clinical laboratory fee schedule revisions, and how long is it going to take? We just don't anticipate that they're going to drill that far down before March 31st. Now, there's the possibility that they may extend the reporting period, that they may delay the penalties, and that they may even delay their revisions to their schedule. But it is wise on the behalf of a laboratory who determines that it is indeed an applicable laboratory to go on that website to access that Excel spreadsheet template, to fill in all the information as honestly and completely as possible, and go ahead and hit that button. Waiting till the last minute, we know from past experience that the CMS website, when there's reporting required, gets overloaded and just kind of kicks people off. So it's in your best interest, regardless, to go forth and do. And now we do actually have some time for questions.
Well, Ann, thank you. We do have quite a number of questions. We'll try to get through as many as we can. First off, do critical access hospitals have to follow this?
Critical access hospitals are not exempt from going through the process of determining whether they are an applicable laboratory. There's no exemption based on the site, the location, the type of facility. They're still going to have to go through the process and determine whether or not they received more than $12,500 from the Medicare fee laboratory fee schedule, and whether or not 50% of their reimbursement came from Medicare from their clinical laboratory fee schedule and the physician fee schedule. So they're still going to have to go through the process of determining whether or not they meet the criteria. It's a case-by-case basis, any way you look at it.
Okay. Oncology drugs are not part of the usual PFS, but are on a separate fee screen. Would that still have to be used in the calculations?
If it is off a different fee schedule other than the physician fee schedule, then no, that would not have to be included. And we did discuss that as oncologists as possibly being below that 50%, but we're not sure because they get reimbursed so little for those drugs now. But they would certainly be an entity that I would recommend doing that, the math for the 50%.
Okay. Another attendee, I thought I saw in your presentation that this reporting is voluntary. Is there a list of applicable labs that we can check to confirm if a lab is applicable?
The reporting is not voluntary. What you saw on the presentation is that laboratories that are not applicable and are not required to report cannot voluntarily report. And I wish that list exists. It would make sense because CMS has all the data. Unfortunately, there's no list anywhere that you can go on and say, I have a CLIA provider before microscopy certificate, therefore I'm exempt, or I'm a pediatric practice, therefore I'm exempt. It just makes sense for every single laboratory to do the determination on their own because there are so many factors, just way too many factors to for anybody to produce a list. It would be nice. It would be nice, but it's not there. Sorry.
So under the Medicare classification, would Railroad Medicare and United Mine Workers Medicare be included as part of regular Medicare for calculation of figures?
Oh, you know what? That wasn't in my research. If the person asking that question would please email that to me, I will get back with you by the end of the week.
Okay. From a coding perspective, can you diagnose a lab test from its result? Slide 17 from its result.
I'm sorry, I'm going to have to go back to that. I'm sorry, I don't understand the question at all.
I'm not too clear on that either. Slide 17 states $12,500 per year. Is it 12?
That is a mistake. It's
okay.
And I apologize to those of you who are listening. You don't know some of the background. This was kind of tossed at me almost at the last minute, so We didn't have time to do very thorough proofing. So on slide 17, it is laboratories that receive less than $12,500 per 6 months. And originally it really was a year, and they scaled it back to 6 months, and it is that set 6 months from the clinical laboratory fee schedule. So I do apologize for that clerical error.
And how does PAMA affect referring labs that bill for reference labs?
So a laboratory that bills for a test that it does not run pass-through billing is not allowed by Medicare, but a laboratory that just that collects tests, collects specimens, and sends them elsewhere for testing, under Medicare, they're not supposed to be billing for those. The laboratory that runs the test is supposed to be billing for them. So I think there's a deeper issue there. But any testing that you send out, you're not doing in-house, would not be a part of the equation. That should be reported by the laboratory that does the test.
And final question, POLs in Florida are concerned how this will impact them because the majority of their patients are Medicare. Will these labs be able to afford to stay open?
That is our biggest concern. My job depends on this, as does theirs. I was totally devastated about this entire process. I think it's going to have a huge impact on, certainly on a lot of the laboratories, not only in Florida, but I understand they have huge retirement communities there. In fact, our daughter has picked out our retirement community in Florida simply based on its name and its mascot. I think there's going to be a problem. I really do, unless this goes away. And this is the feeling of everyone in the industry, that this is going to have a major impact on physician office laboratories. Think in terms of internal medicine, huge Medicare populations. Family medicine, maybe a little less. But yes, I agree. It's going to be a huge negative impact, and we hate that. I'm a laboratorian from further back than I wish to admit, and I'm all in favor of POLs for a myriad of reasons, and I hate it, but I think it is going to have a negative effect.
Well, thank you, Anne. Your webinar was incredible. Please use your contact information if you want to put that back up on the screen. And we do have 2 educational webinars next week. Tuesday the 17th, we have the active shooter in a healthcare facility, planning for, responding to, and recovering from the unthinkable with Steve Wilder. And Wednesday the 18th at noon, avoiding Dr. Google with Jim Cucinato. You can register for these webinars and also request a demo of our compliance solution on our website at 1sthcc.com, or you can call us at 888-543-4778. And she's moving to the contact information. If not, it will be in the follow-up email. And if you send us questions, we will forward them on to her. And the questions that we did not have time to address, we will also send them to her. Your Paycom CU certificate will be emailed automatically. And thank you very much. And Anne, I know you're trying to catch a plane, so thank you very much.
Thank you.
Bye-bye.